Hello and welcome everyone back to our webinar series, Next Steps in COVID-19 Response in Long-Term Care and Retirement Homes. In today's webinar, we will feature a presentation on the use of simulation in long-term care. And more specifically, we will discuss the facilitation of simulation, education, and practice in the context of the COVID-19 pandemic. I will be moderating my session today from my home office in Ottawa, Ontario, where I would like to acknowledge that I am on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. As it is typical for Healthcare Excellence Canada, you can listen to today's webinar in French with the use of simultaneous interpretation. If you wish to listen in French, please select the French from the interpretation menu on the bottom of your screen. We invite you to use either official language when entering your questions in the comment in the chat box today. This session will be recorded and a summary will be available to review or share with colleagues who missed the presentation. So just as a reminder, the Long-Term Care Plus program and webinar series are based on the Reimagining Care for Older Adults report that we published in July 2020, where we identified some promising practices in 6 key different areas to prevent or to mitigate the risks of future COVID-19 outbreaks. So those 6 key promising practices areas are preparation, prevention, people in the workforce, pandemic response and surge capacity, planning for COVID-19 and non-COVID care, and presence of family. We'd also like to thank our many partners who have joined us on this journey towards improvement throughout the past year, including the New Brunswick Association of Nursing Homes, the BC Patient Safety and Quality Council, CADIF, CMA Foundation, and Manitoba Institute for Patient Safety. So I'd like to start today's webinar by introducing Dr. Timothy Willett, President and CEO of Simulation Canada, so that Tim can give us a short background on the concept of simulation education before we introduce our additional speakers today, his colleagues from Island Health Authority. Tim has served as President and CEO of Simulation Canada since 2016 and was previously the inaugural Director of Research and Development. Tim has been working at the intersection of healthcare, education, technology, and leadership since 2005. He is passionate about the transformational and overdue value of simulation is bringing to the healthcare, education, and delivery sectors. As President and CEO, Tim is responsible for the leadership and day-to-day operations of SimOne, the Canadian Network for Simulation in Healthcare. He is honored to be part of this small but mighty team and the network's passionate nationwide community. Tim received his MD from the University of Ottawa and a Master's of Medical Education from the University of Dundee, Scotland. So welcome, Tim, and over to you.
Thank you, Tanya. And I'm based in Ottawa as well. It's always tough to tell where people are. So thank you for inviting me to this. And we can jump to the next slide, please. For those who don't know Simulation Canada, we are a nonprofit network of healthcare simulation centers and simulation professionals across the country. We are interprofessional and cross-sectoral, meaning simulationists that work in the education, the college and university sector, as well as those in the clinical sector, including hospitals and long-term care. A lot of what we do is professional development or teaching people how to teach using simulation, but also advocacy so that we can encourage the growth of simulation into new areas and improve the quality of simulation when it's done, as well as run events and conferences when there's no pandemics, of course, collect and offer resources to the simulation community, and encourage collaborations and join people together. So it's an honor to join you here today. Next slide, please. A quick note about the professional development we offer. We have several courses, including a certificate program that are all train the trainer type of approaches. One that might be of interest is a fairly new one we launched in collaboration with a group from Alberta on system-focused simulation. So using simulation, not just for training, but for actually testing out clinical processes and spaces. Next slide, please. During the pandemic, like so many organizations, we've shifted our focus slightly to consider how we can best support the simulation community. Part of that has been finding and sharing simulations about COVID itself, whether that's treatment or infection prevention or other resources. But also promoting resources and practices for virtual simulations, which are simulations that can be done on the computer. And something called telesimulation, which is running live simulations, but with your audience over Zoom or other web conference platform instead of in the room with you. And also talking and looking into safety in simulation, and in the time of a pandemic, how can in-person simulation be done more safely? And all those resources are free and available to the public as well. Next slide, please. So a quick note about scope here, because often when we say simulation, a mock hospital room usually looks like an acute care room with a sophisticated mannequin might come to mind. But simulation is actually much more diverse than that. I offer a definition here from David Gaba, who's one of the leaders in healthcare simulation. And this definition, like many, focus on the fact that simulation is a technique for replicating some aspect of reality. Not all aspects of the real clinical encounter, but some aspects, for the sake of education or quality improvement. And when we talk about simulation, we often talk about modalities. And modalities are the different ways you can simulate something. So yes, that might mean using a mannequin, whether one that's kind of lower sophistication or has a lot of physiology enabled, but also using task trainers, which are imitation body parts, standardized patients or simulated participants, which are actors trained to play certain roles, virtual patients, which are computer programs, almost like little games to practice clinical situations, virtual reality, augmented reality, and the like. And increasingly, we see use of interactive video, so videos that can actually pause and the learners have to either make a decision or answer a question before the video continues. And then hybrids, which mean using a combination of two or more of these together. And you'll hear about some of these different modalities later in the talk. Next slide, please. I'd like to make a distinction too between two complementary applications of simulation. One is the more traditional application of simulation as an educational tool, where the goal is to improve the individual or interpersonal competencies of individuals or teams. But an emerging and a growing area of simulation is running simulations not for the sake of education, but for the sake of direct system improvement. So running teams through simulations, often in situ, which means in the actual clinical space. And the goal of these simulations isn't the personal improvement of the team members so much as it is to test the system itself. And that could mean processes, procedures, or protocols, or it could be the clinical space, in order to detect latent safety threats and to improve workflows, improve policies, or improve the clinical spaces themselves. And again, as my colleagues present today, you'll hear about these different applications. Next slide, please. And finally, a quick note about evidence. So there's been 20 years or more of growing evidence in simulation that yes, it is a superior technique to traditional educational approaches for most learning outcomes, especially higher level learning outcomes. It can improve individual and team competencies. This does translate to improvements in practice. And there is growing evidence that healthcare quality and patient safety outcomes can be improved through simulation as well. And I've included a few of the key references there for those who might be interested. Next slide, please. Now, one final note before I introduce the speakers you really came here to hear from today. I'd be remiss if I didn't share an exciting update. And on behalf of Health Standards Organization, who we've partnered with, and ourselves, I'm pleased to share an announcement of a new project that is being funded through Health Canada called Improving Care Providers' Competencies in Infection Prevention and Control through Simulation. And the learning from COVID-19 emphasizes the importance of the workforce. of caregivers and residents in long-term care homes to continuously assess and improve their organization's infection prevention and control practices, as well as to build a culture that's respectful of infection prevention. So this project is being funded to design and develop an infection prevention and control practices curriculum using simulation-based techniques to strengthen infection prevention and control knowledge, skills, behaviors, and attitudes, and also test this curriculum with long-term care homes across Canada. It's a 2-year funded project that will be starting soon, and we will be looking to engage long-term care homes across the country. So please do look out for any announcements that might be coming in the next couple of months about that. Now, without further ado, I want to introduce my colleagues from Vancouver Island. First is Darren Abbey. Darren has been a friend and a colleague for many years now and is a tremendous advocate for simulation. He's the director of the Center for Interprofessional Clinical Simulation Learning at the Royal Jubilee Hospital in Victoria. This simulation center is a 3-way partnership between Island Health Authority, UBC, and University of Victoria. Previously, as an emergency department nurse and clinical nurse educator, Darren galvanized his career around a passion for excellence in resuscitation and an ongoing commitment to assuring improved clinician, patient, and organizational outcomes. He's joined by Jayon, who is the Director of Quality in Long-Term Care for Island Health. Previous to this role, she managed a 99-bed complex care home. Her prior clinical experience was as a section head of microbiology in a clinical laboratory, and she's completed a master's degree in health administration. Caring for our most vulnerable in the last phases of their lives with dignity and respect has brought Jayon to work in long-term care. And finally is Tamara Young, a clinical nurse educator for Island Health Simulation. Prior to this, she worked as a critical care nurse in the adult ICU, CCU, and PACU. Experiences working in the Northwest Territories and in the PACU education led her to follow her passion in simulation education and to bring that into her current role. So thank you very much for having me. And at this point, I will hand over to my colleagues on the West Coast.
Well, thank you. Next slide, please. We really appreciate this opportunity and are really grateful to Healthcare Excellence Canada and Simulation Canada for that introduction and this opportunity to join you all from coast to coast to coast. Tamara and Jayon will be joining in due time. Next slide, please. We also would like to acknowledge that we are on the unceded and traditional territories of the Coast Salish here in beautiful British Columbia. And invite you to take a moment, just reflect on your ancestry and the relationship with the lands where you are today. Next slide, please. A quick disclosure. Our team is grateful to have received funding for a portion of this project from the Long-Term Care Plus initiative earlier in the pandemic. And so thank you for those resources. Much appreciated. Next slide, please. We'd like to acknowledge the many people who've been part of this project to date. The three of us really are representing a cast of many who have supported and collaborated on this project, and we're really grateful for their efforts. And we thought we'd spend a quick moment and just say a little something about Island Health. So the Vancouver Island Health Authority represents some 30,000 healthcare providers that provide service to 850,000 people here on the left coast of Canada. And I also want to note that in addition to Island Health owned and operated long-term care facilities, our project collaborated with private and some affiliate sites as well. So quite a collaboration all in. Next slide, please. Thank you. The objectives of our time together really are threefold, as you can see. we'd like to describe the genesis of Island Health's long-term care simulation, long-term care teams, or the use of simulation during the pandemic. We want to describe how we took a really novel video simulation from an episode of learning to a full-scale STEM to STERN simulation project. And we also really want to assure some time for conversation and questions. Next slide, please. So the public face of our project is the BC Simulation Network website. And on that page, on those pages, you can find all the resources available for this, available to you for this project. They are open source and free to use, many of which have been translated by our colleagues at Healthcare Excellence Canada, and we really appreciate that. We also want to note that this effort has been reviewed by Island Health Quality Improvement and Ethics Registry, which uses the IRECI framework, which some of you are maybe familiar with. And what that did for us is sort of helped us identify where there may be risks associated with this effort, and in turn helped us to mitigate them. And so we appreciate that collaboration as well. So next slide, please.
Thank you, Darren. I would like to talk about capacity building, spread, and evaluation. So at the beginning of the pandemic, there were a lot of unknowns, fear and anxiety felt by all, and I'm sure you can all relate to that. So to support and alleviate these fears, our long-term care program created COVID resource coaches to help communicate and be a resource for all COVID-related policies and safety measures. An example of a COVID resource coach's role was conducting tabletop PPE donning and doffing exercises for all occupations, in-person sessions. We collaborate with nurses, healthcare aides, food service workers, therapists, recreation team, and housekeepers to practice these exercises. However, our medical coordinator wanted more to prepare our teams. Simulation videos existed for different subject matter in acute care, but nothing for long-term care. So we wanted to create a simulation for a COVID positive scenario for our program. Script was written in collaboration with our site's clinical nurse educator, and the video was created on a non-existent budget using my iPhone with direct care staff as actors. Countless hours of amateur editing was completed on my MacBook at home. The simulation session started to show benefits of decreased anxiety and fear and help build confidence in our direct care staff on what to expect, have a forum to ask questions, and learn about COVID-19. We had a simulation and a facilitator at our site, but we saw the need to spread this to the rest of the 69 care homes. Although we wanted to share our learning tool with other care homes, we did not have the means nor capacity. So we partnered with Darren and his team, the Center for Interprofessional Clinical Simulation Learning, or the CICSL, for better outreach. And with any new initiative, evaluation is important. And we wanted to evaluate the benefits of the simulation for long-term care, as it was a new tool for us. The CICSL team also had that capacity to provide the evaluation piece for our project. Next slide, please.
When Jay Young reached out to us, we jumped on this project immediately, and are so glad we did. Over to you, Jay Young.
I don't think it's me, it's
Oh, sorry, you're right. My bad. I was going to describe, so we jumped right on it. And before we get into those details, friends, we would also just thought we'd share this definition of simulation. And so thank you, Tim, for also doing so. We just wanted to highlight that often simulation is associated with learning, of course, but can often feel like evaluation or testing. And for our project, we really wanted to avoid that. but instead really wanted to focus on learning and practice and really help people gain understanding of the work that they were doing, and really increase confidence. Next slide, please. So when we think of simulation, we really think of simulations not just as the learning episode, but also what happens before and also after. And so just to sort of do a high-level description of some of those segments, simulation facilitators, they prepare scenarios to align with goals and objectives, and they work to incorporate best practices. And as Jayan's mentioned, they develop evaluation strategies, which takes us to the pre-brief. The pre-brief is often described as that time where people first arrive to a scenario, to a learning event, and it's sort of that time from when they first arrive to when the actual simulation begins. And so this is a time of welcoming, of orientation, of sharing objectives and sharing resources. And it's certainly a time where we are really explicit and make effort to create a so-called safe learning environment, or the safe container, or of course, employ efforts to assure psychological safety. So next is the simulation part. And this is a part where we actually practice the practice. And as Tim mentioned, lots of modalities involved in simulation these days. It's come a long way from, some kind of mannequin that does a bunch of things, but rather lots of multimodal. And certainly this project is multimodal. So after that, we get the debrief. And the debrief, or the learning conversation, is sort of where the learning happens. And we'll talk about these segments a bit further. I also wanted to highlight that last segment. So this is where the evaluation occurs, and where lessons learned are gathered, and any action items that may result as because of the simulation, that's when those action items begin. So, all right, next slide, please.
Thanks, Darren. So to assist facilitators navigating through these 5 segments, we introduced 10 supportive documents. Some were from other simulation resources and others we actually created. The first of these is called our simulation support, or as I lovingly refer to it, my North Star. It's our guiding resource. This document pulls all the others in and essentially walks the facilitator through the 5 segments of simulation, highlighting considerations and resources to assist in the before, during, and after stages. This 10-document resource package supports both the facilitator and the participants, as well as ongoing qualitative and quantitative data collection. Each document is numbered on the top right for reference, which is consistent wherever that document is mentioned. And the BC Simulation Network webpage, where these are housed, includes a brief introduction video on the use of the documents. Next slide, please.
Thank you. So we use these segments to create the STEM to STEM program, and really tried to use our efforts and the sort of resources that Tamara just described to help some 65 COVID coaches or aspiring simulationists to do this work in upwards of 70 sites. So as we carry on in this presentation, we'll go through the different segments and describe things both at the simulation level, but also at the programmatic level. So we'll start by talking a little bit about the preparation phase. So again, we took this video that Jayan created in her kitchen and really wrapped around it with our before and after resources, really trying to help stakeholders clarify what were their objectives, and similarly, how are we going to measure this? And of course, we had a whole lot of capacity building to do. Some of these facilitators had never participated in a simulation, let alone facilitated in one. And so we also needed to and wanted to create that structure at the after section on how are we gonna capture and spread this work. Over to you, Tamara.
Thanks, Darren. At the simulation level, we created resources to assist facilitators to collaborate on securing and informing participants, signage to ensure that bystanders, residents, and families were aware of our efforts. And we also had the use of a pre-in-situ simulation safety checklist. And before we describe how we actually implemented all of this, we wanted to spend a minute describing this checklist. Next slide, please. So the in-situ simulation safety checklist establishes safety and shared decision-making with leadership to run the sim. If the simulation is canceled, and that could be for low staffing levels or high acuity, it provides space to document the reasons why. In addition to these go and no-go considerations, there's a table to account for resources, such as equipment or mock clinical supplies that you would bring in for the session. And it ensures safe removal from the clinical setting after the session has completed. Next slide, please. Oh, previous one, sorry. Thank you. I just wanted to make note that this is one of the documents Healthcare Excellence Canada has kindly translated into French. We can go to the next one, thank you. So as we mentioned in preparing, we were building facilitator capacity, and part of this is providing workshops to support facilitators in the before, during, and after phases of the simulation process. We were supporting a group of facilitators, as Darren had just mentioned, that many had had no experience facilitating a sim or even participating in one. So to support this group, we modified our existing facilitating simulation workshop to create a condensed version, and this targeted their specific long-term care content. During this workshop, we walked through all the supportive resources for the 5 segments of simulation and provided opportunities for facilitators to practice debriefing techniques that were specific to the videos. And to date, we have run 17 facilitator training sessions and now have a team of 65 long-term care simulationists. Next slide, please. Darren, to you for the program level.
Thank you. So with respect to the prebrief, at the programmatic level, we really wanted our facilitators to understand the psychological safety business and really appreciate that though we created a resource to support them, it wasn't scripted. You couldn't just sort of say something and create psychological safety, but rather it needed to be genuine. And it really, as we like to say, it kind of infuses the work. It's psychological safety is like the weather. It sort of acclimatizes the seasons, and similarly, psychological safety acclimatizes the learning environment.
At the individual simulation level for the prebrief, we helped our facilitators to do things like gather attendance data, host introductions, assign the roles, set the stage for the session, and really work towards creating that safe, supportive learning environment. And our prebrief support document is one that assisted the facilitators in this process. Next slide, please. Thank you. So this tool is the Prebrief Debrief support, and it provides a draft pre-briefing script. And this is intended to establish logistics, share objectives, review expectations, and describe the simulation and the debrief. This supports contributing to psychological safety by sharing with our participants that as facilitators, we commit to providing as realistic and as safe of an opportunity as we can. And in turn, we invite them to accept the unrealistic aspects of the simulation. We ask that they join us from a place of respect, curiosity, good judgment, shared fallibility, and positive regard. Next slide, please. And the simulation sessions involved a novel approach, which was viewing videos followed by reenactment. Next slide, please. So this approach involves assigning roles where we share resources, viewing the video and asking those participants to prepare to reenact, doing the reenactment and practicing our practice, and then that's followed by debriefing. The resources provided to support participants include a participant handout and observation tools for the practice of donning and doffing PPE. We also included clinical resources such as long-term care facility policy and procedure. And I just wanted to mention that this image you're seeing is taken from the interprofessional team huddle video. Next slide, please. The initial videos created by Jaeyeon and her team transition through 3 parts, which are done usually in sequence. The 3 parts are a suspect case of COVID-19 where the resident is experiencing symptoms, a suspect case of COVID-19 where the swab returns positive, and a positive COVID-19 resident who becomes palliative and passes away. Each simulation session is an average of 30 minutes in length. Next slide, please. And we have since added 2 new video offerings, which were funded by the Canadian Foundation for Healthcare Improvement. First, communication to a family member of a potential COVID-19 resident, as well as an interprofessional team huddle. And the communication video was informed by the Canadian Guidelines on Disclosure, and Jayon will speak more to those shortly. Next slide, please.
Thank you. I'd like to speak now about the debriefing aspect of this project. Next slide, please. So sharing with you there a definition of debriefing, which we share from the Center for Medical Simulation, which is at Harvard. And as you can see, these colleagues describe debriefing as a conversation between 2 or more people to review a real or a simulated event in which participants analyze their actions and they reflect on the role of thought processes and psychomotor skills and emotional states to improve or sustain performance in the future. Next slide, please. So for this project, we took a debriefing approach that looked something like this. We supported our teams to invite the discussion around participants' reactions. We wanted to hear how they were feeling during these simulations and during these reenactments. And then we shared strategies to facilitate the conversations and really with an aim to assist participants in meeting the learning objectives and really to learn with, from, and about each other. So this, as you can see, is followed by the summary. And during the summary, we aimed to increase confidence and identify key takeaways, action items, and learnings from the sessions. Next slide, please. So we appreciate that during these conversations, there's lots of things you can talk about. And, you know, our participants have things they want to talk about. And naturally, our facilitators have things they want to talk about. And every now and then, something pops up that you really have to talk about. So we helped our facilitators juggle and negotiate these 3 different subject matter sort of content, as it were, and really tried to help them co-create the agenda, but really focusing all the while on emphasis on the learning objectives, emphasis on addressing safety, learning from success, and again, circling back to what those learning objectives are. Next slide, please. So as Tamara mentioned, we did create supportive resources. We showed you the list and you've seen the Prebrief document. And this is the flip side of that document. This is the Debrief document, which again, we invite our participants to use. And we're also happy to share that this document was also translated into French. So we're happy to have that. And thank you again to Healthcare Excellence Canada for that. Next slide, please. So we thought now what we do, before we get into discussing the after simulation segments, is share a small clip from one of our videos with you. So this is a clip from part 1, and this is, again, where a resident has experiencing symptoms. And what you're seeing now is the team responding, and they are posting PPE guidance for the team. They are clearing a path down the hall. And what we'd invite you to do now is have a watch and a listen to this 30-second clip. And as you're doing so, I'd like you to imagine if you were the facilitator, and this team of participants you're working with had watched the video, and now they were reenacting this part, this small 30-second part of the scenario. What kind of beautiful questions might you ask? What kind of questions would you ask to facilitate sort of a conversation that would help us all appreciate what this episode of care is like from the care provider perspective, maybe from bystander perspective, maybe from resident perspective? So just invite you to consider, what beautiful question might you ask? Play the video, please, if you would.
And hang the appropriate signage at the door. And then I'm going to clear the hallway of the residence.
Thank you. So hopeful that during that small 30-second clip, you get a feel for how these videos played out and what they may have looked like. And similarly, that you may have had an opportunity to kind of think of as a facilitator, what kind of question might you ask to generate conversation, shared understanding around these episodes of care. Next slide, please. So let's drift into the after simulation segment. And so we'd like to share now some of the tools that we used. Next slide, please. So after each individual simulation, we invited our participants to complete session evaluations. So these evaluations asked Likert scale questions, self-reporting of confidence, in which were directly aligned with our learning objectives. I also provided our participants with a place to provide us other comments as they might choose to do. And to date, we have 300 participants, all of whom agree or strongly agree that they have met their objectives of increased confidence. In addition, 100% of our participants would recommend these simulations. Next slide, please. So we also ask our facilitators to do some submission of work for us. And so this is the attendance record, which gathers demographics and such, but it also has this summary form. And so it's on the summary form that documents sort of our programmatic learnings and action items. Over to you, Dana.
Thanks, Darren. So as implementation progressed with the simulation sessions at different care homes that were facilitated by our COVID resource coaches, employee feedback indicated that more simulation topics were needed. An interprofessional huddle concerning a COVID-19 positive resident and having disclosure conversation with a family member of a COVID-19 positive resident were two needs that were most commonly identified. The LTC Plus pandemic program through the Canadian Foundation of Healthcare Improvement, now Healthcare Excellence Canada, was made available to long-term care operators. We applied for funding so that we could create 2 more videos. This funding allowed for these videos to be professionally filmed and edited by our digital multimedia services at Islands Health and to have a more polished appearance for end users. And with that funding, we were able to backfill staff to participate in the videos. Employee engagement is so critical to buy-in for learning. So we asked members of our interdisciplinary team to participate in the video creation from script writing to acting. We also leveraged CPSI and Safe Care BC resources to inform best practices. In addition to this, with the family disclosure video, we had the privilege to collaborate with patient partners. For both videos, we had robust interdisciplinary review, feedback which provided noteworthy changes. An example of that is the new healthcare support worker who was added to the huddle. With any quality improvement project, discoveries are made. Our project highlighted opportunities to improve infection prevention and control. These were documented in our provincial patient safety learning system. And then we engaged our stakeholders, including our regional infection control practitioner, which resulted in local mitigation. We then brought these findings forward to our regional quality council for knowledge sharing and discussion. Some future considerations are to hold or offer quality boot camps and hiring quality resource coaches to build our quality team in long-term care. Next slide, please.
we're really excited to work with Jay on moving forward and see how we can use simulations to further support her teams and particularly sort of inserting it into that boot camp. So the last resource that we'd like to share is this, which we call a Kirkpatrick evaluation. And this is also being translated. And so this is a resource that's crafted to try to collect the future impact of a simulation. So the idea is that at some future time, participants would identify which simulation they attended, take a note of their reactions to it, and identify what knowledge, skills, and attitudes they may have acquired, and then to share the changes in behavior and that may have occurred and how in turn those behaviors impacted the residents and or the delivery of care. So that's really our attempt to make that link that Tim was talking about earlier, how simulation changes learning and it also changes experience and outcome. And so that's our attempt to try to gather that. Next slide, please. So lastly, we really encourage our teams to celebrate. And so at this time, we'd like to invite Tamara and then Jae-Young to add a couple of comments.
Thanks, Darren. I think I'll just share what I say to my newly trained facilitators at the end of each of our facilitating simulation workshops. I truly believe that each time they host a session, no matter how long it lasts, whether that's 5 minutes or 45, they're providing an opportunity for education, team building, and culture change in an incredibly difficult and challenging time. So I always tell them, for me, you showed up. That's a success. This was a huge effort for them, and it's been a pleasure to meet all of the individuals that I had through this process. Over to you, Jae-Young.
Beautiful, Tamara. I decided I wanted to quote Albert Einstein. In the midst of every crisis lies great opportunity. We had great opportunity to learn from the pandemic, spread that knowledge, build capacity, and foster new partnerships across our organization. It was quite an experience, and I am so honored and privileged to be part of it. And I decided to keep my day job after the brief stint in film editing.
Thank you. Well, what would I celebrate? I guess from my perspective, we have some 70 simulation facilitators. As we mentioned, many of whom had never even participated in a sim, who have now worked with 300 participants, all of whom agree that they are more confident in working in their long-term care settings during the midst of this pandemic. And for that, I really am grateful to this strong collaboration and really invite you to reach onto the webpage and have a look at our resources. We'll be happy to discuss them further with you. Next slide, please. So that's what we mean by the segments of simulation. And that's what we mean when we describe how we've taken those segments and really transitioned them from our focuses on just an individual event, but rather to a STEM to STERN simulation program, which is now really focused, it was now really sort of refocusing our approach to all of our efforts. And so we're grateful for that. So next slide, please. We hope that we've met these objectives in describing how we got here and the development of this program, and are hopeful now that in the time we have left, we can answer what questions you may have and or any curiosities that you may have. And next slide, please. So again, here's the QR code that links to the long-term care project on the BC Simulation Network webpage. Here is a email that you can use to connect with us if you want to talk about this and or other collaborations. And so on that note, I again just thanks Simulation Canada and Tim for that introduction, and certainly great gratitude from all of our team to Healthcare Excellence Canada for inviting us to share today. Thank you all. Really appreciate what you do.
So thank you very much, Darren, Tamara, and Jayon. I don't know if you see all the kudos coming through the chat, but our long-term care participants found this webinar extremely stimulating and engaging, but there are many questions. So perhaps, Darren, I will actually, I'm going to ask Jayon the first one because it's about the videos. I hear you're the videographer. So from Albright Manor, what technical specs were used for the equipment to video the scenarios?
Well, the initial video was done on my little iPhone 6S, my work cell phone. I did try to use a microphone in my fancy Canon camera, but it was not working. It was much easier and more mobile to use an iPhone. And then with Apple products, they have iMovie, so I use that with many, many hours of editing at home. We had an hour and a half of footage that I pared down to 16 minutes. And we divided up into 3 segments. But our digital media services team had more sophisticated cameras and microphones and better editing ability with their software programs. So you can see the difference between the amateur videotaping and the polished look of the 2 funded videos.
Great. So the next question will be for you, Darren. So for the evaluations after the simulations, are they submitted? Are they pen and paper? Do you do them electronically? So I guess, how do you capture those? And that's from Julie Ware.
Yeah, thank you for the question. So they are pen and paper. Because we were after the Likert scale and self-confidence and the, would you recommend, and also free comments. And the simulation summary is also paper. That said, they're both gathered electronically, and that's how we are sort of looking at the data and trending and being able to report out. So a bit of both and anonymous to us.
Great. So the next question, I'll go to Tamara. So from Lynn Filatro, amazing work, congratulations. She would just like to know, what role did family and clients play in the project in influencing the topics, and what success looked like from their perspective?
That's a great question. Thank you. I think the first comment that would come to mind for me is when we did the communication video. We engaged our patient partner network here to help us accurately represent the perspective of what it would be like for a family member. And our patient partners were contributors to the script itself and helped us to develop it. And it were part of the development process the whole way of that script and video. And then prior to that video's creation, I just would mention that when we did our facilitator workshops and we were doing the training, we did spend some time in the practice sessions really chatting about how can we support from the perspective of the residents. And that would have different intricacies depending on cognitive functioning from the residents and what facilities they came from. But we would practice techniques of how could we share with the residents of the care home what we were doing. How could we bring their perspectives in when we were debriefing and engage the residents, because this is their home, and how this education would influence them. And when I checked back with some of the coaches that were doing that work, the feedback from the residents who were engaged was quite positive.
I'd love to just add quickly to that.
Go ahead, Darren.
Yeah, thank you. I really love this question, and thank you so much for asking it. I'm seeing that it really represents a huge shift in simulation, which used to really be about meeting people's learning objectives or organizational objectives, and increasingly is embracing the nothing about me without me movement. And I think that's really good news. And so bringing, residents, bringing patients, bringing community into our work from the get-go is increasingly showing up in SIM. And so I love that question, and certainly our teams are trying hard to rise to that challenge.
I just wanted to add one more comment to that.
Go ahead.
The biggest driver for the way we crafted and scripted these videos is because it is resident and family centered care. And our long-term care program has 4 core values that we really want to practice every day. And that's connection, learning, integrity, and collaboration. And we worked really hard at making sure that the script writing was centered on those 4 core values. That's why it was important to have resident and family feedback on them.
That's great. So the next question, I'm going to go back to Tamara because it's about the workshops. So I guess there's a question from Sheila Smith in Winnipeg asking, can you share more information about the workshops and when and how to register? But I think that your workshops are just offered in Vancouver at Island Health. So I'll let you elaborate.
Yeah, I wish we had more workshops around. Right now, we're just specifically, these workshops are for the Island Health COVID coaches who work in long-term care. But if they're interested in how, from a simulation perspective, we designed the workshops and what core content we hit on, they're very welcome to reach out to our, I believe it's cecil@vha.ca. Darren is the email if you're interested, and we can share some of the, I would say, the foundational, framework concepts that we introduced in these workshops to support our facilitators.
Yeah, we'd be super happy to collaborate. If you want to employ this project in Winnipeg, please just give us a call. It's all open source.
I have lots of slides for you.
That's great. I love this, building capacity in other provinces. This is fantastic. So just reading a few additional comments before I jump to the next question. So Charlene Austin, CHE, says, congratulations on fostering innovation during some of the most challenging and complex conditions in our country's history. So it's very inspiring. Jen Plant from the Pearly Rideau in Ottawa says that we started using simulation a few years ago related to housekeeping and IPAC, and have since implemented simulation on a number of topics, including falls preventions, huddles, pain orientation, and having difficult conversations. They've also engaged residents and families in this work and had positive feedback. Their collaborative practice leader has completed the Sim1 training and has been a fantastic experience. So thank you for sharing your amazing work. I don't know if you have comments about these comments that are coming in.
This is only the beginning for us. In my new role, I plan on new projects with Darren and his team. We're already talking about some of those projects. So yes, this is exciting times for us.
So lots of comments around impressive use of innovation. I know there was one other question. Oh, here it is from Charlene. So Austin again, CHE. So could families be trained as facilitators? So I don't know if Darren, you want to start?
Yeah, that's a great question. Absolutely. I believe families can be trained as facilitators. I mean, I think facilitation with families is also showing up in the literature. We have some colleagues in the Lower Mainland in Vancouver who we know have been doing this. I think what it would, yeah, absolutely. I think, when facilitating, co-facilitation brings such a rich experience for people. It's a bit hard to do, which doesn't mean we shouldn't do it. So I would say, yes, please.
So another question from WINM. So do simulations include translation for care aides, nursing teams with English as a second language? So maybe I'll go to Jayon first.
Oh, that's a really good question. We didn't think of that. I'm sure anything is possible if we find the right translator to provide simulation to that degree. So far, it's only been in English. So we'd have to look into that.
That's great. And maybe I'll just end with one more comment. So in your experience, do simulation attendees report having increased confidence in responding to COVID-19 challenges? And if so, where have you seen those increases? So I'll start with Tamara, and then we'll work our way through to Darren and then Jayon.
I'll let Darren and Jay speak more to this, but our data collection, all of our evaluations is yes, absolutely. Everyone is reporting, as Darren had mentioned in the slides, either strong or incredibly strong increased confidence when it comes to this. And I have a lot of conversations with the COVID coaches after the workshops and their ongoing work, and they tell me that they see that with their colleagues on site if there's a potential COVID patient, not only are they seeing confidence improve, but they're seeing an impact on the stress levels, which I think is really important.
Yeah, thank you. So confidence has been our main metric. And as mentioned before, we were interested in aligning our learning objectives with self-reporting of confidence of our participants. So each one of our simulations has a series of self-reported Likert scale questions, and over all of them, 300 participants have said that they strongly agree, or they agree with statements such as, I am more confident in. And so we're really, really proud of that.
I also wanted to point out, it wasn't just our direct care staff our healthcare aides and nurses that participated in these simulations. It was multidisciplinary. So we had housekeepers and food service workers and activity workers participating in this. So it really brought down the anxiety and fear and did build confidence, just feeling more comfortable with PPE donning and doffing, especially because that is an important part of this whole pandemic. So it was all really good feedback.
That's great. Well, I think we've answered all the questions, and there's a final comment that you need to spread your amazing work and consider presenting at the BC Quality Forum next year. So clearly you have inspired many people on this call today. So thank you very much for this engaging conversation. There are many requests for resources, slides, the recording, so we will be happy to share all of these resources with you following the webinar. So now as we look to what's up next for the Long-Term Care Plus series, we have a huddle on May 27th at 2 p.m. Eastern that is focused on the Dementia Isolation Toolkit with the University Health Network. And on June 14th, our virtual learning series will continue with a panel discussion around deprescribing during COVID and beyond. And this is with the groups that we're currently working with on our appropriate use of antipsychotics work in Quebec, which is also known as OPUS, and the PEPS initiative, which is a broader deprescribing initiative, and of course our former appropriate use of antipsychotics collaborative participants. So please complete this evaluation survey as we close out, and let us know if the webinar provided useful information and whether or not you intend to share what you learned with others. And for more information, please reach out to our website or email us at the email address on the screen. We look forward to working with you throughout the year. And thank you again to our presenters. It was a very inspiring conversation.